Let us discuss about anterior cerebral artery infarction today. So let us first start with the cerebral circulation. So the cerebral circulation is constituted by the anterior circulation, which is the internal carotid artery and its branches, and the posterior circulation, which is constituted by the vertebral artery, the basilar artery, and the two posterior cerebral arteries. So both of these circulations together constitute the entire blood supply to the brain. Let us see this in this diagram. So these are the two vertebral arteries which are joining to form the basilar artery, which is further dividing into two branches, the posterior cerebral arteries, right? Now this is the internal carotid artery, which is giving the branches anterior cerebral arteries, the posterior communicating arteries, which are connecting the anterior and the posterior circulation, and the middle cerebral arteries, right? So all of them together constitute the circle of Willis, which is constituted by the anterior cerebral arteries and the anterior communicating arteries in the front, the posterior communicating arteries, the posterior cerebral arteries, and the basilar arteries on the back. So this is the entire circle of Willis, which constitutes the blood supply to the brain, right? The same thing is represented in this diagram. So today we need to focus on this anterior cerebral artery. So this anterior cerebral artery is connected on either side via this anterior communicating artery. Now what if there is a occlusion of this artery? This occlusion could be proximal to the origin of this anterior communicating artery, which is known as the A1 segment of the anterior cerebral artery, or it could be distal to the origin of this anterior communicating artery, which is known as the A2 segment of the anterior cerebral artery, right? So what if there is occlusion in this A1 segment? So now if there is occlusion here, there would be no symptoms. Why? Because the opposite side anterior cerebral artery via the anterior communicating artery would supply this side as well. So there would be no reduced blood flow on either of the sides, and therefore patient would have no symptoms when there is occlusion of the A1 branch or the ACA branch proximal to the origin of the anterior communicating artery. Now what if there is a obstruction in this A2 branch, that is distal to the origin of this anterior communicating artery? So in that case, this part of the brain would undergo infarction. So which is this part of the brain? This is medial surface of the frontal lobe, right? So what is the motor and sensory representation here? We know that the legs, the foot, and the urinary bladder or the genitalia is represented on this side of the brain. So all this part would undergo infarction, right? So what would be the symptoms here? The symptoms would include number 1, contralateral weakness of leg and foot. Similarly, contralateral sensory loss of leg and foot would be there, right? Apart from that, there would be urinary incontinence because of the involvement of the paracentral lobule, which has the representation of the urinary bladder, right? Apart from that, three other things that we need to remember here is, number 1 is akinetic mutism and abulia. So as the name represents, akinetic, that is patient would be immobile, and mutism, that is patient would not speak but patient is conscious. So this happens when there is a frontal lobe lesion. Abulia is also similar to akinetic mutism, but it is a milder variant of akinetic mutism. So both of them will also be observed if there is a lesion to the frontal lobe. Apart from that, there would be a reappearance of primitive reflexes like contralateral sucking reflex, contralateral grasp reflex. So these will reappear if there is a lesion to the frontal lobe, and there would be Gingen-Halton rigidity. So what is this Gingen-Halton rigidity? It is a paratonia. That is, the tone of the muscles is increased and it is proportional to the amount of resistance that the examiner applies. So if I try to pull the patient's hand like this, patient would apply the same amount of resistance as I am applying and prevent this movement. So this is known as Gingen-Halton rigidity. It will affect both the flexors and extensors equally, right? And the last thing that is seen here is gait apraxia, right? So what is this gait apraxia? Apraxia is inability to perform learned skillful movement, right? So learned skillful movement, patient is not able to perform. So what is gait apraxia? That because there is a contralateral weakness and sensory loss of the legs, so there is a difficulty in walking, and this is known as gait apraxia, right? So these are the 6 things that we need to remember if there is a occlusion of the A2 branch of the anterior cerebral artery. Now again looking at this diagram, so this is our anterior cerebral artery and this is how it is supplying this medial surface of the frontal lobe, which is the paracentral lobule, the motor part and the sensory part, and will cause the symptoms as we discussed in the previous slide, right? So A1 occlusion we have already discussed. Patient would be asymptomatic. Why? Because of collateral flow through the anterior communicating artery. A2 syndrome, we have discussed the 6 symptoms. Contralateral weakness would be there. Contralateral sensory loss would be there of the lower limbs. There would be urinary incontinence would be there. Contralateral grasp reflex and sucking reflex would appear. There would be Guggenholter and rigidity. And this happens because of the involvement of the supplementary motor area of the frontal lobe. There would be abolia and akinetic mutism, which again represent damage to the frontal lobe. And there would be gait apraxia. So these are the symptoms that is seen in A2 occlusion. Now, what if there is a bilateral A2 segment occlusion? When would it happen? It would happen if both the A2 segments are supplied by a single A1 branch, right? So this would happen if there is atresia of the A1 segment of the opposite side, right? So both the A2 segments are getting supplied from the same A1 branch. Now, what if there is a occlusion? In that case, there would be bilateral areas would get affected, right? So there would be bilateral motor and sensory loss of the legs on both the sides, so which will manifest as paraplegia, and all other symptoms would remain the same. There would be urinary incontinence would right, and there would be profound abulia. So all these symptoms would be there if there is a both A2 segments are getting occluded. So what we need to remember here, that this is an important differential of paraplegia, right? So when we suspect a stroke, what do we get done? We get a MRI done, right? So earlier we used to in resource limiting centers, still we get a CT scan done. But if we have a MRI available, in that case we should get a MRI stroke protocol done, right? So what is there in this stroke protocol? There is a T1 weighted sequence which will show this hypo intensity in this ACA distribution, right? And this T2 weighted sequence which will show hyper intensity in this sequence, right? So this is what we get in a classical MRI, T1 and T2 weighted MRI. But these sequences can be normal in acute ischemic stroke up to 6 hours. So the other sequences that we are getting done in a stroke protocol is a diffusion weighted imaging and a ADC. So the advantage here is a hyper intensity on a DWI and a reciprocal negative, that is a hypo intensity on an ADC, would confirm an acute ischemic stroke, and this is the earliest sequences to show changes of an to show changes of an acute ischemic stroke, right? So therefore, if we do not know the time of onset of stroke, and if we get a hyperintensity on a DWI and a hypointensity on ADC, that means this patient is a candidate for thrombolysis. So this is the advantage of getting these sequences done, that they help in the earliest diagnosis of stroke, right? Ischemic stroke. Another sequence that we get done here, this is the 5th sequence in a stroke protocol, that is an MR angiography of the brain. So we can see the blood flow in all these vessels, right? What is seen here is a block in this left ACA branch, and therefore the left ACA branch is not seen here because of a block here, right? So this is what how this helps us to diagnose that there is a occlusion of this left ACA branch. So this is we discussed the anatomy, the clinical features, and the MRI imaging changes of a ACA infarction. Thank you.